Alright, why don't we go ahead and get started? How do we get started with some introductions? So why don't we start with Sue? Oh, I think you might be muted. Sorry about that. Do you mind trying one more time for us? Thank you.
Yeah. Sue Westfall, family physician at Cabin Creek at Dog.
Perfect. Thank you so much. And Amy?
Hi, I'm Amy Lively. I'm the care manager for New River Health Association's MAT.
Perfect. Thank you so much. And we have a number ending in 5749.
This is Douglas Harvey calling, case manager for WVU Medicine.
Perfect. Thank you so much. And a number ending in 4956.
Hey, this is Megan Klein. I'm calling from WVU Medicine Population Health.
Perfect. Thank you so much. And a number ending in 1300.
Yes, John Linton, the Dean of the Charleston campus, WVU.
Perfect. Thank you so much. And Dr. Hirschler?
Yeah, hi, I'm Chairman Hirschler. I'm an addiction psychiatrist here at the Lakewood Center in Cheat Lake.
I'm Philip West, clinical therapist at Lakewood.
Perfect. Thank you so much. And Beth?
Therapist, Crystal, our RN, will be joining us soon, too.
Perfect. Thank you so much. And everyone over at Trinity Family?
My name is Hunter Keister. I'm the case manager here at Trinity.
Perfect. Thank you so much. And Lois, everyone there with you?
Yes, it's me, Ryan Morrison, the physician medical director of the MAP program at Kanawha City Health Center. You can see Lois here. And then in the back, we have Bailey Hendricks and Catherine Darby.
Perfect. Thank you so much. And John? Thank you. And Laura Simmons?
Hi, Laura Simmons, behavioral health case manager with Minnie Hamilton.
Perfect. Thank you so much. And we have C. Buffo. Are you able to hear us? There's a username C. Buffo. If you're having audio issues, you can chat us on the side as well. And Joshua Witt. Okay, you can go ahead and chat us as well if you have some audio issues. And Adina.
Hi, I'm Adina Bo, Charleston WVU, our MAT program. Nice to be here.
Perfect, thank you so much. And Joshua says they have no mic or video here from NHS. Thank you for joining us. And Jay Linton.
It's Nikki from Grafton City Hospital, and I too do not have any video. I have this on my phone.
Okay, perfect, thank you. And Peacock Brenda. Okay, you can go ahead and chat us on the side as well if you'd like. And a number ending in 5749. I believe we actually already went over that. Sorry, Douglas. Let's see. Okay. I believe that's everyone. Why don't we go ahead and introduce ourselves in here?
Sure. Tony Dikiaki, family nurse practitioner at the Review School of Nursing.
Hi, Mitra Watashan, project ECHO coordinator.
Jim Berry, addiction psychiatrist here at WVU Morgantown. I'm Laura Lander, social work faculty at WV Medicine Morgantown.
Okay, perfect. Thank you so much. So anytime you guys are ready, Ryan and Lois, I can pull up your case if you'd like. Was there one you wanted to start with first in particular?
I don't have a favorite case. Either one is fine, but right now I'm having difficulty getting video for the case. But I had it briefly a moment ago.
Right. So you have audio okay, but it's just the video that isn't coming up for you?
Yeah. I'm not sure why it went away.
Found us over there on the side and see if our
Well, any ideas on why the video would cut out? And I could probably present this fairly blindly without the video.
Right. Let's see. So I can pull up the case and show it for everyone, and on your end, I guess you can, I can email it to you as well if you'd like and go through it like that.
Yeah, that'll be fine. Email it to Lois.
Okay. One moment. Let me email that.
Oh, wait, no, it came up. We have video.
Got it.
No email
You
needed.
got it? Okay, perfect. All right. Is this case okay to start with?
Yep, that'll be fine.
Okay, perfect.
All right. So, let's see here. Okay. This is a 55-year-old male that presented to us recently. He's a Medicaid patient. Seemed to have like a long history of polysubstance abuse. Basically, actively using every possible drug in existence. So the reason I picked this case for presentation, the questions I have for this case are, the guy had came in, we had called him in sort of unexpectedly while he was on the wait list and one morning and to start therapy. And so he came in, but when he got here, he had had 1 or 2 beers already before we had ever called him. And so he had a low blood alcohol level on the breathalyzer. And so one of the first questions is, should recent alcohol use or the low breathalyzer for alcohol result in me not starting therapy that day? Absolutely. Additionally, this patient had a very remote history of DTs, which was, I'm not sure it was even DTs, but he thought he had them at some point. So I encouraged inpatient therapy, and he said he couldn't go. So the next question will be to think about is, should we put someone like this who's ever had a history of DTs into, and there has been recent drinking, into be willing to do outpatient therapy at all? And then the third question for discussion will be, the person had also had a coinciding script for gabapentin, and whether and how we should handle that, particularly since he filled it after leaving my clinic when he said he wouldn't. So, he's currently using opioid pills and alcohol, but has a 20-year polysubstance use history with heroin, meth, sedatives, and pretty much everything else. He claims he has a demented mother, although there was some uncertainty. Some of my staff members felt that the demented mother may be not real. Although he exhibits no symptoms of psychosis, the demented mother, the concern was some of the staff had actually lived near him and knew of him and who he was, and thought that his mother had already passed away. So So we weren't sure if the demented mother was completely made up in order to have an excuse to not go inpatient. And he's also been using it as a reason that he can't participate in 12 steps, can't make it to IOP visits and so forth, because he can't get anyone to watch his demented mother. So as I mentioned previously, when I was going through the questions, he had a low level of breathalyzer, alcohol of 0.04, and had reported a few beers that AM. And he's known also from my staff members, sort of have a reputation of being from a group of individuals that are heavy alcohol users. But he reports that his recent alcohol use isn't that significant. Just a few beers here and there, and he's mostly using opioids, and that that he did not think he would have any difficulty with immediately and completely discontinuing alcohol at his arrival day one. So yes, he has a very remote history of broken back, disability, and uses OxyContin and oxycodone for pain relief as well as pleasure. And as I mentioned previously, he's used practically everything: benzos, heroin IV, Roxy's currently, no Adderall or stimulants for a while, but had used methamphetamine IV just the day before coming to me. So that stimulant, obviously, yes. He was not tweaking or acting really abnormal at all. He would not have known he was intoxicated at the time of presentation.
What about the gabapentin?
Yes. So he's got a regular prescription for gabapentin. It's not on this list. He's used Suboxone Street. His drug screens was listed up there. He doesn't seem drunk. He just is very low level blood alcohol level in terms of appearance, physical exam, no tremulousness, no slurring of the speech, no myotic pupils, no skin changes or tooth loss of methamphetamine use. So I was really conflicted with this patient, and he wanted me to give him as much Suboxone as I would be willing to day one. I wasn't sure I wanted to give him anything day one because of the blood alcohol level. I decided ultimately to go ahead and prescribe it for later in the evening, but not have him take it there with me, and to warn him, of course, no alcohol with it. And then part of the deal was that he would discontinue gabapentin, and basically he left my clinic and went straight to the psychiatrist after obtaining a Suboxone script for 8 milligrams day one, and picked up gabapentin from his psychiatrist's prescription. He's got some comorbidities, blood pressure, back, thyroid, and really just doesn't follow the primary care, probably many, many more comorbidities. So what happened next with this case was the patient was supposed to come back the very next day, but he came back 2 or 3 days later, right. And he basically said that he had his girlfriend pick up the gabapentin, and he tried to tell her to stop it, but couldn't stop her in time. But we called the pharmacy, and they basically confirmed that it was he himself who had picked up the gabapentin at the pharmacy that same day. And then
he told us he had a twin brother.
He reported that was his twin brother, and that we need to stop being so suspicious. Since then, till the time we got here to present this case, it's been a couple weeks, and basically he just came like intermittently. I told him he was going to just have to come daily until I could talk to you guys because of all the stuff that was going down, and he only came like one day more, but then he came back
Friday. And today.
Yes, I think he's come back 2 or 3 times since then, but very like irregularly. He just goes without Suboxone sometimes. He says he can't get here because of his demented mother, and but he has consistently shown up with maintaining abstinence with clear UDS except for Suboxone.
Right again.
Oh.
Oh, yeah, he did use Lortab
Oh,
Friday.
except one time, yeah, when he ran out of Suboxone, he used the Lortab, and he we've been sending off for our ETG, ETS, and I don't think we've seen any positives. So it seems that he's abstaining from alcohol without even with just intermittent Suboxone. He I didn't get to the gabapentin story. Got rich. He says he reported the gabapentin. Where did it disappear to? He could never return it to us, though.
Right.
He said he returned it to the pharmacy. We asked the pharmacy, said no, they did not return it to us. So who knows where the gabapentin has been? He assured us that he could not return it to us and never has. So basically, we got a very, very tough situation. So I've been this morning though, because of the fact that he's been consistently showing clear UDSs and no evidence for alcohol. We've been doing blood breathalyzer every time, and it's always 0.0. I decided to go ahead and give him 4 days of medicine till Friday, even though I had told him initially I was going to keep him daily over all the gabapentin stuff and all the alcohol and concerns that he was going to go into DTs if we did this as an outpatient. But my concerns have gotten less on that. So after reflecting on this, I guess I'll just put it back to the group to give me what their thoughts are on the original questions from the case regarding should I have done it differently with starting him on Suboxone on the day that he had positive breathalyzer? Should I have done it differently with the gabapentin handling? There was one other thing on the case I've forgotten. One other question.
About 12 steps, wasn't it? Was it
Yeah,
12
he said he
steps?
can't do 12 steps.
Well, on 12 steps he says he can't do, so I've been considering just letting him have an exception and do online only if you guys think that's fair. So
Was that one of your questions as well that you had?
the 12 steps thing was not as high a priority as for me as getting your all's thoughts on trying to treat someone with alcohol positive breathalyzer without inpatient therapy.
Sure. Thank you so much for that. Were there any questions or comments about that case specifically? Wanted to ask everyone out there.
Ryan, when he's really drinking, how much alcohol does he put away?
He says he's been known to drink 45 beers in a day. Kathy saw him hitchhiking with a case of Old Milwaukee, but that's the day he tested negative for alcohol. So we don't know.
And it wasn't his twin brother.
It was not his twin brother.
He really put me at ease about it on the day that I gave him the Suboxone to start, Dr. Hirschler. But then after the gabapentin thing happened, I got to where I was hearing these reports from my staff. I had concerns that he was a heavy alcoholic, but it has been 2 or 3 weeks now, and I feel like the ETG and ETS and the breathalyzers have been pretty reliably, consistently, completely negative. So I don't think he's drinking any alcohol, or at least he's avoiding. He's timing it perfectly to squeeze in between the times that he doesn't come and the ETG. But he's not normally going more than 3 or 4 days without coming in, and we're sending it off for ETG every time. So I would say he's at least 2 or 3 weeks now with minimal to no alcohol.
We also got a chat from Sue. She asked, how reliable is the negative ethyl gluc at initial visit?
Well, based on the ethyl gluc discussion that the WVU lab director had with us, it's highly reliable when you have it very negative for recent use, like within 12 to 24 hours, and much less reliable after 24 hours. But for a heavy drinker, we should get more like 48 hours of reliability. Maybe even 72.
Were there any questions or comments, recommendations for anyone in here?
So my thought is there's a lot of unknown, right? So in a small community, I mean, you can't make this stuff up, right? Hitchhiking with the case of Old Milwaukee. Perhaps he's taking that to someone at his home. So, I mean, we have to believe the objective tests, which are that he's either made significant changes or not drinking that much, which to me is a sign that he's trying to adhere to what you're asking him to do. Now, he may not be in the stage of change that we would consider to be action, but he's, maybe somewhere headed towards, contemplation and preparation. And so meeting people where they are sounds pretty important, especially for him who's had a long history of substance use disorders and has some comorbid medical issues that, could become severe if he continues to use substances. And so it sounds like he's actually been coming at least twice a week. Is that right, Ryan?
I think about twice. I will not say twice at least, probably 1.8.
Okay. Yeah, I mean, in a funny way, based on what you described, and there's been some evolution where he's doing a little bit better than initially it seemed like he was. I mean, unless you're going to go to his house, you may never know if he's being honest about his mother and his mother's state. It sounds like you guys checked up on the pharmacy, so there was some evidence of him lying about that, but that was pretty early on in his entering treatment. In terms of prescribing when someone has alcohol in their system, you want to talk about?
Yeah, the other thing I would say is, before I get into that, is most of the people who are coming in, a lot of them anyway, the first time they come in, they're going to be really messy. And to just so everyone who hasn't done this yet, you got to understand that a lot of folks are not going to be put together and as compliant or honest as we would want them to be. But our goal is to keep them engaged, and hopefully as they continue to work with us and us with them, then they'll be able to accomplish some of those changes, such as becoming more forthright, in addition to stopping those substances, because they don't know what to trust yet either, as much as you don't know what to trust. They don't know what to trust with us. And like you, Ryan, I would be strongly suspicious that the guy actually had DTs. A lot of times when people come in, or even it might be in the medical record that they've had DTs, people don't know what delirium tremens is. And a lot of people will think that they've had DTs because they've gone through some sort of alcohol withdrawal. And that might be just having some shakes or getting sick from alcohol withdrawal, but not the severity that would reach true delirium tremens, which could be a medical emergency. Regardless, he presented, and he may have had a blood alcohol registration on the breathalyzer, but from what you're telling us, he didn't appear intoxicated. And if somebody didn't appear intoxicated, unless his blood alcohol level was especially over the legal limit, I would have done what you did and started him on Suboxone right away and have him come back with close follow-up, exactly like you did. So I wouldn't have had really a reservation of starting him on it. And then over time, realizing and monitoring and recognizing that he probably really didn't need inpatient detoxification for alcohol, that he would be fine just stopping as an outpatient, which apparently, again, by all objective indications, he has ceased use. So I think I probably would have done pretty much what you all did with him. Definitely would have started him on the Suboxone with the hopes of him coming back.
What would have been your reaction for the gabapentin, us, Tall Tale?
Yeah, again, first coming in, I would be much more lenient than what I would if somebody had been in the program for a while. So I would say, okay, listen, I don't believe your story. You're going to tell it to me. That's fine. However, moving forward is I cannot see you. I cannot pull up another Board of Pharmacy report and see that you filled another gabapentin prescription, another Neurontin prescription. Then that's going to be, we're going to have another conversation about what that means and what this program is about and whether or not this is an appropriate program for you and what the requirements or the consequences would be if we saw that. But early on, there's really not much that I wouldn't make a great point about it beyond what I just said.
We also got a chat from Sue. She says, how do people deal with frequent missed sessions, and how would you handle this case if initial ethyl gluc was high?
Sounds like the second question was already answered.
Yeah, and just to kind of follow up, make sure I'm clear on that. If the blood alcohol level was high, I would probably tell him to come back the next day so I could reassess, and I wasn't comfortable giving him a medicine that could make him toxic with that kind of blood alcohol level. Or if somebody appears intoxicated when they see us, there are times where we would have them come back the next day. And basically the conversation is, we want to help you. Right now, you appear too intoxicated for me to be comfortable prescribing. However, if you come back tomorrow and you look like you're in a much better state of mind and behavior, then I would be more than willing to begin the medication at that point. So back to Sue's question for everyone else, how do you deal with folks who frequently miss your appointments?
Here at Kanawha City, they just go without their meds, and usually they don't miss too many because of that. But this particular patient, I will say, he did know to show up on Fridays, so he knew not to miss one that would be a more than 1 day appointment.
Yeah, usually for our patients who do that, we have them we just increase their level of care. We ensure that they're not having transportation issues, because it might be something simple like, oh, they need a Medicaid van or so forth. We've also found that we don't give the medications. If they miss the appointment, they don't get the medication, so they tend to start coming after a while. We had an initial problem with a lot of drop-ins. They would come in times when groups and things are not scheduled. And initially we were trying to accommodate that, but it became a problem, so we had to stop that. And now this year we're finding people are a lot more compliant with their visits.
Were there any other questions or comments? Perhaps if you've seen a similar situation at your clinic. Did you guys have any other comments or questions as well? Or
This was of least importance in the case, but you brought it up as far as considering having him go to online meetings and have those all the requirements. I would recommend against that and keeping him in the group where everyone else has to go to in-person meetings. So unless you're going to make that a programmatic change for everybody, I would recommend against that, as it can become a slippery slope and then also sort of breed resentments from other folks who are actually doing it.
I really like actually when you give me recommendations for being strict, because then I can blame their negative response on you, Dr. Berry.
Yeah.
And say, Dr. Can me force this on you? I tried for you.
Yeah.
So that.
Yeah.
Mr. Barry, you're the bad guy so many times around here.
Yeah. What's that? Didn't hear that one.
I said,
yeah.
Either me or you.
So I know you have a didactic, Dr. Berry, and I had another case. I don't know if we have time for both. So I would make you more important than me. My other case is a good one, but it's definitely not time sensitive, so I can put it off to next time.
Sure, absolutely. I was actually going to ask you guys, do you want to do that case for the next session on February 10th?
That'll be great.
All right, perfect. We'll save that for you guys next time then. Thank you so much for that case, and thank you everyone for your questions and comments and recommendations. So anytime you're ready, I can pull up your didactic.
I'm ready.
All right. Do you want to control it yourself? Yeah. And I can pull it up on like a full screen if you like.
Do I advance it right here?
Yeah, you can hit the arrow or click that as well.
Okay. So is this good?
Yep.
All right. So what I thought would be helpful for everyone to become familiar with is the National Survey on Drug Use and Health, which is an annual report I'll talk about in a minute. The most recent one for 2018 came out several months ago. So I was going to review the data that we have primarily for opioids. I'll talk a little bit about some other things, but primarily review what these surveys reveal about opioid use for 2018. So what is it? So the National Survey of Drug Use and Health, it's a household survey that consists of interviews of substance use disorders, mental health, and receiving treatment in the United States. So what they do is they collect face-to-face information via these interviews, and then when they get to more sensitive questions, they transition the respondents to these audio computer assessing self-interviews for these sensitive items. So it's both a face-to-face and then an individual computer audio questionnaire. It covers the civilian, non-institutionalized population, age 12 or older. So it includes people who are actually living somewhere. This could be a regular house, a college dorm, or in a shelter, or civilians on military bases. It's important to know that it does not include military, long-term hospital residents, the prison population, and the homeless, which is one of the significant weaknesses of the National Survey of Drug Use and Health, because it does not capture a lot of people who are out there on the streets with substance use disorders and mental illness. But this captures people who actually have someplace to live. It's performed in all 50 states and the District of Columbia. It's a really large sample size, one of the largest sample size of epidemiologic surveys in this particular area of 67,000 people every year. Briefly, this is the number of people who have serious mental illness. You can see the blue line. We've got 19 million people age 18 or older in 2018, which is one in four had severe mental illness. And then on the other side, 7.8%, 19 million people age 18 or older had a substance use disorder. Of those who had a substance use disorder, 3 in 8, or 38%, struggled with illicit drugs. 3 in 4, about 75%, struggled with alcohol use, and 1 in 8, about 13%, struggled with illicit drugs and alcohol use. And in you could see the middle circle there, 3.7% or 9.2 million people had both an SUD and a mental illness. So a lot of people in the United States who are suffering mightily from both substance use disorder and from mental illness, and there is a large proportion who suffer from both together. I wanted to include this here to show the co-occurring substance use and suicidal thoughts. And just this goes from 2000, I can't see, it's somewhat blocked, but I believe it was from 2005 or 6 to 2018, I believe, but I'm not sure about that. But anyway, look at the dramatic jump in people who had serious suicidal thoughts. This was people who did not have an addiction, and then compared to people who do have an addiction, and how large that is. So 70% of people who've had a substance use disorder have had suicidal thoughts. And then those who have actually made a plan, if you didn't have a SUD and you did, it was 1.2 million people, 6.6%. And then for those who have attempted suicide, those who did not have a substance use disorder was only 0.4%. Those who did have a substance use disorder got all the way up to 3%. So this is something that I think should be at the forefront of our minds and considerations if we are dealing with people who have substance use disorder. This is also a pretty good informative slide that looks at the past year treatment reception by different populations. And you can see in the far left, this is for substance use disorder treatment, 20.3 million who had a substance use disorder, and almost 90% of them did not receive treatment. This is for, the next is 46.6 million, and 56% who had any mental illness did not receive treatment for their mental illness. And then next you could see serious mental illness. So this is beyond any mental illness, serious and non-serious, and this is for just the serious mental illness. And 11.4 million people, and 35% had no treatment. And next would be co-occurring any mental illness and substance use disorder, 9.2 million, 90% of which did not receive treatment. And then you could see the 3.5 million with major depressive disorder. This is the adolescent population, 12 to 17%. And it's obstructed there, but I think it was 50% did not receive treatment. So this is a slide that simply highlights our need to expand access to both mental health and substance use disorder treatment. We are in a desperate state of need to do this. Now, this looks at changes from 2017 to 2018. You could see that marijuana use had a significant jump from 2017 to 2018 to over 15% increase, which is certainly a result of increased availability among states that have legalized both medical and recreational, and the decreased perception of harm among a population regarding cannabis or marijuana. Next would be the psychotherapeutic drugs, and so these are prescription drugs and controlled substances, and this is the bar that includes prescription pain pills. So the good news is from 2017 to 2018, there was a significant decrease in people who were misusing pain pills. So you could see the numbers there. And then cocaine, hallucinogens, methamphetamines, inhalants, and then heroin at the bottom. You can see all of those. So this is for the opioids, the pain pills, and heroin. 10.3 million people with opioid misuse, which is 3.7% of the total population in 2018 misused opioids in the that past year. Good news is 5.5 million reported hydrocodone misuse, and which is a significant decrease from the 11.4 million in 2017. 3.4 million oxy users, which was another decrease, and 269,000 prescriptions for fentanyl. Now, keep in mind, this is the fentanyl prescription and not illicit fentanyl that one would buy on the streets that was made in labs. 9.9 million prescription pain reliever misusers, which accounts for the vast numbers of opioid misusers is still prescription pain pills. So you see this 97%. And then over on the other side, which is the green box, 808,000 heroin users. So that was really a small minority of those who had misused opioids in 2018 to represent about 8% of those who have used. And then the bottom box is 506,000 prescription pain relievers and using heroin as well. And that accounted for about 5% of opioid misusers were people who were using both prescription pain pills and heroin. And this is a slide that shows from 2015 to 2018. I'm able to pull that up so I could see everything. But I'll go ahead and show this. So 2015 to 2018, so you can see 8.7 million to 5.6 million, which is a significant decrease. Now I'm hoping to get the title slide too. I don't know if you could pull it up there or not. Thank you.
Sure.
Sorry, everybody. And so then from 8.7 million to 7.7 million, another decrease. And this is, I'm sorry, this is 18 to 25-year-olds is that top graph. And then the 26-plus-year-olds, again, it stayed relatively flat and had a good decrease. And then also the 12 to 17-year-olds also had a nice decrease. So in all of these patient populations, the biggest population decrease was among the 18 to 25-year-olds, but you saw a nice decrease in the other age groups as well.
Again, sorry about that. Yeah, should I go back a little?
Yep, keep going back. There we go. All right.
Okay.
Next do. All right. Shoot. Can't see any of that. So this is the prescription pain reliever misuse, and this is among the age. Can you get that box back down?
Oh, sure. I could pull it up for you here too.
That would be fine, but can everybody else see the?
Sorry about that.
You can't hide the bar.
Let me see.
Okay.
I'll try to move this one as well for you. Is that okay?
Yeah, that's fine for this one, but I'm worried about another one.
Yeah, I can move it again for you if you'd like.
All right, so this is the blue bar is 2015, and then the green bar is 2016, the gray bar is 2017, and then the blue bar, the dark blue bar is 2018. And so you can see with the pain relievers, that first grouping, again, what we've already described is there's been a significant decrease in the number of people who have been misusing pain pills. And pain, so this is pain, essentially opioid pain pill use disorder has stayed relatively flat with a little bit of decrease over since 2015. The next is pain reliever misuse initiates. So the people who have actually started their misuse with pain pills has declined as well. And then the next corner is heroin use. And you can see that there was an increase from 2015 to 2016, little decrease in 2017, and that decline continued in 2018. So that's the good news. And then those with heroin use disorder or heroin addiction, you could see that it steadily increased from 2015 to 2017. But the good news is those with heroin use disorder declined in 2018. And the number of people who started using heroin for the first time, again, you had a bump from 2015 to 2016, went down to 2017, and did have a bump up in 2018. So that's something to continue to watch. But if people aren't using heroin for the first time, and those numbers are going down, then you would expect the use disorders to go down as well. So this is pain prescription misuse among age groups, pain pill misuse. Again, a nice decline from the 12 to 17 age group. And then also another nice decline among the 18 to 25 age group. And you could also see that demonstrated in the 26 or older age group. This is a series of questions asked every year in the survey about where does somebody get their opioids that they're misusing. And every year that this survey has been in place, which I believe at least since 2006, they've been asking this question, is every year the most common source by which somebody is getting their opioids is from a friend or a relative. And either they're buying these or they're being given to them. Now, keep in mind that these questions would include a question such as, have you ever taken a pain pill from a friend or relative? And most of us, if we have been alive long enough, we've probably gone to a friend's or a family member's house, had a headache or something of that nature, and have asked for a pain pill or to something with their headache, and maybe have been given a opioid. So that would include something as innocuous as that to something as very serious as buying pain pills to actually misuse and abuse. So what is always interesting and has been consistent too is you look at the next largest wedge in this pie, which is that blue color, and that is the second most common means by which somebody has got their pain medication to misuse, and that's a prescription from one doctor. So a lot of us tend to think that doctor shopping is the main reason why, or the main route by which somebody's getting pain pills, but it's really not. That's one of the minor routes. Really what's happening is they get it from one doctor, and interestingly enough, you look at, okay, so you ask those people who got their pain pills from a friend or a relative and ask them, well, where did that friend or the relative get their pain pill? And 83% of the friend or relative state it was prescribed by a single doctor. So really it still is a question of making sure that doctors are truly educated and practicing best practices regarding the pain pills that are being prescribed to their patients, and making sure safety standards are in place to keep them from being diverted. Next is the misuse of opioids by their subtype. And so this first orange box is hydrocodone. So 5.5 million misused hydrocodone last year. You can see that makes up 11.5%. Next is oxycodone, which is 12.8% of oxycodone was misused, and then 9.4% codeine, or 2.4 million, and 1.5 million of tramadol. Interestingly enough, for all of us on the call, the highest rate of misuse among these surveyed was buprenorphine, 28.3%, or 718,000. And then morphine is the next box. It's that gray box, 8%, 486,000. And then methadone would be number 2 behind buprenorphine as the highest rate of misuse at 23.5%, or 256,000. And then fentanyl prescriptions, mind you, was a rate of abuse at 12.7%. Now, you look at the gross actual numbers, and the other medications besides buprenorphine and methadone far outstrip the misuse in gross numbers. So you could see where the buprenorphine, that red column, is 718,000 compared to, for instance, the hydrocodone at 5.5 million. And so the vast numbers are still the regular opioid pain pills that are being misused, but they are having a higher rate of misuse among those who are an MAT. which to me is not surprising since you have a larger proportion of patients who actually have addiction who are being prescribed MAT. So that should not be that surprising, but it should continue to be a clarion call for all of us to make sure that we're practicing what we preach as far as safeguarding the medications that we are prescribing and doing so in a way that will minimize the misuse.
Is misuse defined as not taking as prescribed?
Yes. Yep. Heroin use climbed through 2016 and then has been declining. Heroin use, and this is among the age groups, so you can see that it is continuing to decline in the 18 to 25 year olds, which has had the sharpest decline, and then for those 26 and older, it's remained relatively flat, and the 12 to 17 year olds has remained relatively flat as well. Next, heroin-related opioid use disorder, so essentially heroin addiction. You can see among the 18 to 25 year olds that had the sharpest decline in addiction, and then the other age groups that remained flat. So this is a cool slide that shows, well, an interesting slide that shows the treatment gains that the number of people receiving medication-assisted treatment over the years. This is from 2016, the blue, to 2017, the orange, and then 2018, the gray. You can see the increase from 345,000 to 450,000 in those receiving methadone over that time. You can see the increase in buprenorphine as well from 520 to 648,000, and then naltrexone from 46,000 to 73,000 over that period of time. And then the totals you can see from 2016 to 2018. So the good news is we've had a positive trend in the number of people who have been able to have access and actually have received medications for their opioid use disorder. It still does not match the need that exists, but at least it's a positive trend. So the summary from the opioid use is significant decrease in prescription opioid misuse across all age groups. The majority continue to obtain from friends and relatives and from healthcare providers, underscoring the need for ongoing education of practitioners, appropriate pain management, and partnership with states to monitor pain pill prescribing. Buprenorphine continues to have a high rate of misuse relative to other prescribed opioids. A decline in overall heroin use from 2016 to 2018 with some differences among age groups. The decline in young adults, which constitutes the 18 to 25-year-old age group, heroin use is responsible for the overall downward trend, where remember the other age groups remained relatively flat, so it's the young adults. This has had the biggest impact last year on. Heroin use disorder, young adult use disorder decreased significantly compared to 2017 and was steady in adults 26 and over. The total with OUD decreased from 2.1 million to 2.0 million. So that's good. We would love to see it go further than that, but at least it does show that. Now remember, these are folks who are diagnosed with OUD, and these are folks that have a home. So you can imagine that this is just capturing a portion of the OUD that exists out in the population. And we also had seen in 2018 an increase in MAT. Some of the other substances, I threw this in there too. Marijuana, no changes in youth use, but significant increases in adults over age 26, which was interesting. The older adults made up the bulk of that increase. Significant increase in observed in marijuana use disorder among the 18 to 25-year-old group. Marked declines in illicit drug use by pregnant women, particularly marijuana, which is good news. There was an increase for several years in pregnant women using marijuana, and last year showed a decrease, which is great news. The bad news is that you saw some of the sharpest increase in marijuana use was among non-pregnant women. Declines in cocaine use in adolescent and young adults, declines in meth use in young adults 18 to 25, but significant increases in meth use in adults over than 26 and older. Significant decline in prescription stimulant abuse in 18 to 25-year-olds, decrease in hallucinogen use in adolescents and young adults, but significant increase in adults 26 years old and older. So we're seeing a pattern among those who are 26 years old and over who are increasingly using more and more substances. I wanted to include this in here because what the National Survey of Drug Use and Health did not really capture is what all of us are kind of really worried about, which is the synthetic opioids like fentanyl. So right here, for instance, is that blue line. This is 1999 and 2007. This is not the National Survey of Drug Use. This is CDC data. But you can see the blue line is the prescription pain pills, which has been relatively flat. But and then also heroin is that green line, which has been flat from 2015 to 2017. But what's concerning is you could see that since about 2015 to now, we've had this sharp increase in the number of overdose deaths, which has been mainly attributable to fentanyl and other synthetic opioids. And so that really has not been captured the way I would like on the national survey. Next. So this shows overdose involving prescription opioids. Okay, this is the number of overdoses. This is prescription opioids without other synthetic narcotics. And you can see this is the bottom yellow line. Again, where people are using opioids, if they're using the pain pills, that there's been a sharp increase in mixing those pain pills with fentanyl and other synthetics. You could see the same thing, a decline in just using heroin and a sharp incline in using heroin in combination with the synthetics like fentanyl. And what probably most of you can attest to as well, the vast majority of patients who are coming in with opioids these days are using fentanyl, powdered fentanyl. They may think it's heroin or still call it heroin, but when you ask them, almost everybody says, yeah, it's really fentanyl these days. And so that's what has really driven up a number of the deaths, and this is something that we should all pay attention to.
Okay, perfect. Thank you so much. Were there any questions about Dr. Berry's didactic? And I will be sharing the PowerPoint and the recap email later as well, so you all will have a copy.
Yeah, and if anybody wants to see, you could always go to the SAMHSA website, and you could see Dr. McCants Katz, who is the head of SAMHSA, who actually presented this data. So there's probably about a 45-minute video of her report on this. You could also pick up all of the slides, not just the ones that I stole for this presentation, but all of the slides there as well.
Thank you so much.
I was interested in the information about people seeking care for opiate use disorder and mental illness, and the low percentages of people actually seeking treatment compared to the number of people affected. And you said that access to care was the key to that. Do you think there's stigma and cultural issues that play a role in that as well?
Yeah, I think so. I would say that access to care is one of the issues, but it would also include people not even believing that necessarily they had a problem or wanting to get their problem addressed if they did recognize a problem. And absolutely, stigma still plays a part in somebody who would want to seek either mental illness treatment or SUD treatment.
Thank you.
Are there any other questions or comments out there? All right, well, thank you everyone so much for joining us today. I do have one quick announcement. So our next session is going to be on February 10th at 4 p.m. and Katie Chazin-Downs is providing our didactic on social stigma, and Lois and Ryan will kindly present their case for next time as well. So we look forward to seeing you guys next time, and thanks again for joining us.
Thanks, everybody.
Bye.